Good evening, everyone. My name is Mary Pruden, and I'm the director of the National Keratoconus Foundation. Today is World Keratoconus Day, where we invited people to help raise awareness of keratoconus, and several hundred individuals and groups from around the world shared their stories and educated others about keratoconus on social media. I hope you participated. If you visit worldkcday.com, you'll see some of the events that happened today, as well as an interactive map that showed some of the international KC community. Tonight, as a conclusion to World Keratoconus Day, the National Keratoconus Foundation is hosting this webinar on crosslinking. This webinar will kick off a year of learning that we're planning. We intend to host webinars throughout the year, like this one, on topics that interest the KC community. We hope you'll join us for future webinars. We'll have information about speakers and topics on our website, nkcf.org, or on our Facebook page, National Keratoconus Foundation, or on our message board, KC Link, as they become scheduled. The way this GoToWebinar is set up is that you'll find a text box on your computer screen. If you want to ask a question about some of the information that we present tonight, you can type your question in that box. If our presenter has some time after his talk, he may be able to answer some of your questions. This webinar is being recorded and will be available permanently on nkcf.org starting next week. If you would like to hear it again, or you want to invite other family members to listen, we hope you'll send them to our website. I'm happy to introduce tonight's speaker, Dr. Sam Garg from the University of California, Irvine. You may be aware that NKCF became part of the University of California earlier this year, after 3 decades as a standalone nonprofit. UC Irvine is a public university, part of the UC campuses. It has an undergraduate division of 25,000 students, as well as a medical school and a medical center and hospital. Although NKCF provides information to people worldwide, we're physically located in Irvine, California, in the Department of Ophthalmology. This has been a great move for NKCF. I have ODs and MDs who are expert in treating keratoconus and eye disease right down the hall. Dr. Garg, our speaker, is a cornea specialist who participated in the cross-linking clinical trials that led to the FDA approval of the Avedro equipment and protocol earlier this year. He has performed cross-linking on keratoconus patients, and tonight will be giving us some background on the procedure, how it works, and if cross-linking is something you might consider. He'll give you some useful information that might help you when you talk to your own eye doctor about cross-linking. Dr. Garg graduated from the New York Medical College and completed his ophthalmology residency and fellowship in the treatment of corneal diseases and refractive surgery at UC Irvine. Currently, he's our Vice Chair of Clinical Ophthalmology. He is an active member of several national and international professional societies. On behalf of the National Keratoconus Foundation, welcome, Dr. Garg.
Well, thank you very much, Mary, for the very kind introduction. It's my pleasure to speak today on World Keratoconus Day on collagen cross-linking, and very excited to say it's finally here, and really excited about this technology for our patients with keratoconus, and also for those who have post-LASIK ectasia. As Mary stated, I am at the Gavin Herbert Eye Institute at the University of California, Irvine, where I'm a associate professor and vice chair of clinical ophthalmology, along with being medical director. So when we look at keratoconus, this is a condition that is actually quite common, and it's a bilateral progressive corneal bulging that results in irregular astigmatism and loss of visual function, usually with onset in the teenage years. This is important a couple key points in that first bullet point is that, we usually see this in younger patients, not always, but usually, and it is progressive. And the goal of cross-linking is actually to halt that progression or slow down that progression, and we'll talk about that a little bit later in the talk. The other thing that happens with keratoconus is that you get an irregularity of the cornea. The cornea is the front window of the eye, and glasses and contacts can fix some regular changes in the cornea, but once things get warped from keratoconus, it can sometimes be difficult. So the goal is to try to prevent that cornea from becoming irregular. Currently, there's no cure for keratoconus, and it's important to realize that cross-linking is not a cure for keratoconus, but it is a viable treatment to help prevent progression. It's been estimated that keratoconus affects about 1 in 2,000 people, and we know that cross-linking for the treatment of keratoconus was granted orphan designation by the US FDA due to its rare nature and was recently approved this year. On the right, you'll see a couple pictures. One is of a keratoconic cornea, and you can see sort of the bulging of that cornea near the center there. And on the right side is sort of the right lower box is a picture of a corneal transplant. Corneal transplantation has been one of the mainstays for end-stage keratoconus, and the goal is with cross-linking that we'll have less and less of these procedures going forward. So when we look at the cornea is made up of multiple layers of interweaving collagen fibrils, and the cornea has 5 main layers to it, but the biggest layer, which is called the stroma, has these interwoven collagen fibrils. And the thought is that people with keratoconus, there's a weakness within the fibrils in which there's not enough interconnections. So if you think about a bridge without the struts, that bridge won't have any rigidity. And so patients with keratoconus, the thought is there's not enough struts in between those fibrils, and that may then lead to progressive weakening of the cornea and then resulting in bulging of the cornea and thereby keratoconus. So this is a picture of a keratoconic patient, and if you look at them head on, you may not be able to tell anything major going on. Certainly you can see a scar in the lower left-hand part of the cornea. This was a patient whose corneal keratoconus was actually quite advanced and was ready for a corneal transplant. But on side view, you can see how, in fact, bulging the cornea is, and with a disconnect between the visual axis, or the pupil, and the actually apex of the cornea. And this results in tremendous blurring of vision and irregularity that, unfortunately for this patient, was not able to be fixed with glasses or contacts, and therefore they opted for a corneal transplant. So keratoconus, we have treatments to improve vision. Certainly in the beginning stages, we always start with spectacles, and then we often have to move to contact lenses. The reason for contact lenses is they sit on the eye, and by being on the eye, you're able to treat some of the distortion with the tear film filling in the space between the contact lens and the cornea, thereby decreasing the impact of that irregularity. There are various contact lenses available, soft contact lenses, rigid gas permeable contact lenses, piggyback lenses. Now we have scleral lenses, which are quite effective for this, and others as well. Another potential treatment to improve vision in keratoconic patients are intracorneal ring segments, also known as intacs in the United States. These are little plastic segments that are placed in the periphery of the cornea to help buttress the cornea and decrease some of the astigmatism. Sometimes these are used as a bridge to allow patients to fit contact lenses. And as I alluded to earlier, corneal transplantation is still a viable treatment option for keratoconic patients, and about, thankfully, less than 20% of patients require this. The problem with corneal transplants is, depending on when you get them in your lifetime, there's a very good chance you might need one again. It's predicted that 73% of grafts fail within 20 years and 98% at 30 years. Luckily, keratoconic patients have amongst the best outcomes with corneal transplants. compared to other groups because of the non-inflammatory nature of keratoconus. There's, as I mentioned, these grafts can last a variable amount of time. So, as this disease afflicts younger patients, there's the potential for needing multiple transplants over a lifetime. And the Eye Bank Association of America noted that there was over 6,900 transplants a year in patients with keratoconus. The problem is none of these treatments alter the natural course of keratoconus. Crosslinking was first studied in Europe at the University of Dresden in the late 90s. And it's a medical procedure that combines the use of ultraviolet light and riboflavin. And the thought is that by administering riboflavin to the cornea and then administering UV light, you generate a chemical reaction that forms crosslinks between the different layers of the cornea. And so by doing so, you can stiffen the cornea. We know that the cornea stiffens with age, and the thought is that crosslinking actually accelerates that stiffening. So by crosslinking the cornea, you create new collagen crosslinks, resulting in shortening and thickening of the collagen fibrils, and then that leads to stiffening of the cornea. When we look at some of the laboratory pictures, off to the right, you can see a cross-linked cornea on the upper right with the bridges in between the fibrils, and then a cornea that has not been cross-linked with less bridges that is then weaker. And when we look at the picture on the left, you can see a cornea that is a keratoconic cornea that has not been treated with cross-linking. And that might even be a regular cornea that has not been treated with cross-linking, and then a cross-linked cornea, which shows some rigidity when held in the air. So the cross-linked cornea, which here is depicted in yellow, is much stiffer. So when we look at, as was mentioned by Mary earlier, Avedro went through a very rigorous clinical trial process to submit to the FDA, and earlier this year was approval for their cross-linking platform. And in clinical studies reported to the FDA, the cross-link treated eyes showed an increasing improvement in their keratometry, which is a measure of the steepening of the cornea from months 3 to 12, while the untreated eyes demonstrated steepening. So what that means in layman's terms is that the cross-linked eyes stayed stable, but the eyes that were not cross-linked continue to steepen. And that has implications in progression and thereby vision and progression of keratoconus. So in the various studies, they found various amounts of reduction of steepening as well in the treated groups. And the importance there is cross-linking, practically speaking, is meant to halt keratoconus where it is. But in some studies, we find that sometimes it actually does improve some of the metrics that we look at on the cornea, which may have implications in best corrected vision down the line. Although that's not always uniform, that is hopefully something we will continue to see as we start to gain more experience with the technology. So in April 2016, the FDA approved collagen cross-linking for the treatment of progressive keratoconus to Avedro, and this is a picture of the unit. It's a very sleek unit that is quite mobile and can be used in an office-based setting. And they also have two formulations of riboflavin, and these have different indications depending on the thickness of your cornea. So who are good candidates for cross-linking? Well, certainly the focus group that we're talking about today is keratoconus, but there's also a group of patients who have had LASIK and for whatever reason, maybe keratoconus was not detected, and after their LASIK, their cornea starts to progress. It's important to know that the current indication for cross-linking is progressive disease. So generally speaking, keratoconus is diagnosed in your late teens or early 20s and progresses, through your early 30s. So if you are 45 or 50 and your keratoconus hasn't changed and you're fitting a contact lens well or glasses well, you're most likely not progressive and therefore not a candidate for this treatment. However, if you're younger or just got diagnosed, that's where we have a very good chance to alter the natural course of this disease and halt the progression of keratoconus. Certainly, patients with good vision with either contact lens or spectacles are good candidates because, part of the goal of cross-linking is to certainly halt the progression of the disease. The other goal is to allow patients to have useful and good vision in their eyes. And if you don't have good vision for even with mild keratoconus and because of a scar or something else going on with your vision, then maybe cross-linking may not be your best bet to improve your vision. Certainly, otherwise healthy eyes, there are several things that should be excluded prior to undergoing a treatment like cross-linking. And certainly, to be a candidate for cross-linking, you should be willing and able to cooperate and participate in the treatment and also the post-operative regimen. So what your eye surgeon will tell you about cross-linking is that it's not refractive surgery. Although it may change how well you see, it's not meant to change your vision like LASIK would. Like I mentioned, you may have some changes in your keratometry or the steepness of your cornea, and that may have some implications of how well you see, but really those are quite minor compared to other refractive surgery techniques that we have. So the expectation is that you will still need contact lenses and or spectacles post-operatively, and your vision will most likely decrease initially for the first couple months and then stabilize usually over the next several months and usually be quite stable at about a year. And with any treatment, there can be complications, and what we find in cross-linking is that we see complications like haze, infection, corneal scars that may progress past the initial sort of healing period that we see in other kinds of treatments that are similar, such as PRK. So in a nutshell, the procedure can be done in an office-based setting. The current procedure is what we call epithelium off. The cornea has multiple layers to it. The most superficial layer, the layer that's exposed to the air, is called the epithelium. It's the skin of the eye. That has to be removed. And the reason it has to be removed is so that we allow the riboflavin access to the deeper tissue, which is the stroma. So the riboflavin is soaked onto the surface of the eye and in through the stroma for 30 minutes. Then we have to check the thickness of the cornea to make sure that there's a minimum thickness present in order to then expose the eye to UV light. Subsequently, your doctor will most likely place a contact lens on the eye. This is not meant to restore vision. This is meant to be like a Band-Aid, and then they'll probably give you a prescription for antibiotic drops and anti-inflammatory drops that you'll use for the first several weeks and potentially longer. Certainly, procedures like this can make your eyes feel very dry, and by using lubricant drops, not only do you help the symptoms of that, but you can also help speed up the recovery of your own cells growing over and repopulating the surface of your eye. Follow-up visits, generally after the procedure, you will have a follow-up visit with your physician, either the next day or within the first few days after the treatment, and then with regular follow-up in the first couple months, and then spacing out to your regularly scheduled visits. It's very important that when you have a treatment like this, that you follow the instructions that your eye care provider has given you. And some common ones would be, if you feel like you have something in your eye, don't rub your eyes, especially for the first 5 days or 10 days after the procedure. I mentioned the epithelium having to be removed off the surface. Well, then that has to grow back in. And when it grows back in initially, it doesn't really stick down all that well, and it takes a little while for it to stick down. And if you rub your eye, you have a chance of causing a scratch on your cornea and then having to re-heal all over again. Certainly, right after the procedure, you may be sensitive to light, and wearing sunglasses in the first few days may be helpful. you certainly should not plan on having the procedure done and then going about your normal schedule. I would plan on having at least a few days off from work or school to recover. If your doctor does put on a bandaged contact lens and it falls out or becomes dislodged, don't replace it. Call your doctor and follow his or her advice. And if you're experiencing severe pain or your vision suddenly changes, contact your physician immediately. With respect to the pain, you can expect to have some discomfort after this procedure. Excuse me. The cornea has some of the highest innervation of any tissue in the body. So any kind of disruption of the corneal epithelium is quite painful. So that should be an expectation after this procedure. That's why we place the bandaged contact lens, to try to minimize that pain. Frequent use of preservative-free artificial tears can also help decrease the pain. But if there is a significant change in that pain, you should alert your physician. So in conclusion, cross-linking is certainly, from our clinical trial, found to be safe, effective, it's FDA approved, and finally we have a medical treatment for patients to stop the progression of keratoconus. Very, very exciting for us as an eye care provider in a community who treats patients with keratoconus and other diseases. And so, I'd like to thank Avidro and all the effort they've put into bringing this treatment to our patients in the United States. And with that, I will answer any questions that people may have.
Thank you, Dr. Garg. That was very helpful. One of the listeners asked a question about epi-on versus epi-off. They're not sure what that means, and can you sort of explain that and what that means as far as cross-linking?
Yeah, great question. So when we look at the cornea, again, it has multiple layers, and the surface layer is the epithelium. And the initial studies that have been done have all been epithelium off. And the reason for that is when we remove the epithelium, you get exposure of the riboflavin to the underlying stromal layer. And then you treat with UV light, and then you cross-link. Epithelium-on treatments are placing the riboflavin on top of the epithelium. The problem is the epithelium can act as a barrier and thereby decrease the amount of riboflavin that gets into the stroma. And if there's not enough riboflavin there, that it can also then affect how well it cross-links. There's also some thought that the epithelium may affect how well the UV light is actually able to penetrate through, and that may then affect the amount of cross-linking. Currently we just don't have enough data to know which one, if epithelium on cross-linking is effective. We do know that epithelium off cross-linking is quite effective.
Okay, when you say you remove the epithelium, how do you do that? Is that with a knife, or how is it done?
So another good question. There's multiple ways to remove the epithelium from a patient's eyes. Generally, we will use a dull instrument to sort of just remove the epithelium gently. Sometimes we'll use something to sort of loosen the epithelium, such as sterile alcohol to loosen the epithelium, and then it will come off. And so there's different kinds of brushes that can be used. It's sort of dependent on your surgeon. Okay,
and then does it grow back?
It does grow back. So the surface of the eye, the cells on the surface of the eye, actually grow back quite quickly. And so we'll place that bandaged contact lens on the eye, and then the cells will grow on from the periphery into the center. It's important to know that when we do make this scratch on the surface or removal of the epithelium, it's only for the central 8 to 9 millimeters of the cornea. The peripheral epithelium, which is where the stem cells for the epithelium actually live, are not affected.
Oh, okay. All right, that's helpful. I got another question about having both eyes cross-linked at the same time. Is that something that happens or not?
it's certainly possible. The challenge with having both eyes cross-linked at the same time is when you do cross-linking, your vision will not be the same for a period of time, and which is why we generally recommend doing one eye, letting that eye stabilize, getting good vision in that eye, and then doing the other eye, so that you're not impacted bilaterally simultaneously. The other thing is, in the rare event that there is some kind of adverse event, that is only going on in one eye and not both eyes simultaneously.
Okay. Ellen has written an interesting question, and that is, what are the limitations on physical activity or sports after cross-linking, after you've waited the necessary time?
So after you've healed, you should be able to go back to your normal activities without any kind of restriction. That's one of the nice things about this, because there's no penetration really into the eye. It's not like a corneal transplant where you'll have bending or lifting restrictions. It's a very superficial treatment, and so the structure of the eye is essentially unchanged.
Well, that's good news. Jennifer has written a question, and she wants to know if the bandage contact stays on for a long period. Oh, and then does the doctor take it off eventually?
Correct. So generally, we'll leave it on for 3 to 5 days, during which time you're using an antibiotic several times a day to prevent infection. And the goal there is to, number one, allow your surface cells or epithelium to grow more quickly, and number two, to help prevent discomfort. And it is removed generally by then your eye care provider.
Okay. Justin has a personal question, and he says he's 32 and has the disease. It's stable. Do you have an opinion about any kind of treatment that's actually going to reverse keratoconus? Is there anything down the line that might be more than just to stabilize it, but to reverse it?
Certainly, keratoconus is one of the areas that gets a lot of research, and internationally, and within the United States, there's quite a bit of research going on with respect to different protocols for not only cross-linking but other things that may actually affect the natural history of the cornea. It's really hard to say what's going to come to our practices at this point. I think our current paradigm is to help first diagnose keratoconic patients and try to treat patients that are progressive early, so that we don't get to the point that we have to talk about corneal transplantation in these patients. But I would speak to your doctor individually about potentials for reversing your keratoconus.
Okay, we have a question that's somewhat similar to what we talked about before, about having both eyes done. This person wanted to know if how much time you normally have between doing one eye and then the other.
So I think in the clinical trial we waited about 6 months, and clinical trials are different than everyday practice. I think I would say you would want to make sure that you had functional vision in the eye that was treated before you underwent a secondary treatment in your fellow eye. So that I would think that would be somewhere between 2 to 3 months.
Okay, this is an interesting question by one of the listeners, and he mentions that doctors have statistics on corneal transplant success and that sort of thing. Is there any information out there about success rates for cross-linking?
Internationally, there is. I think we'll get more and more U.S. data on this once more practitioners start performing cross-linking here in the States. Anecdotally, it is a very, very successful procedure with a very low side effect or risk profile. It depends on the actual treatment that's being done and your individual case.
And what would you call sort of a successful? Is that that means a year afterwards you haven't progressed beyond, you haven't progressed at all, and then how many years out are people being followed?
So, I mean, from the early data, those patients are still being followed in Europe. So, I don't think we've seen a lot of progression in those patients. I would have to look up the studies to see if there's anything recent that has come out. But in my mind, if you're stable, in our experience in the study that we were involved in, patients were stable at 1 year and showed some decrease in their keratometry at 1 year. Will that stay stable for many years to come? If we're getting the cross-linking in the cornea like we think we are, my expectation is that, yes, you will stay stable. But again, individuals are individuals, and everyone's sort of response to treatment can be different.
And if you're doing the procedure on patients who have progressive keratoconus, your assumption is, had they not had the treatment, there would have been some progression of the disease in that 1 year time. Is that the thinking?
That's correct. And so, as part of the study that we were involved in, we treated one eye and often didn't treat the other eye. And by and large, the untreated eye would progress in the time between, which was 6 months plus, in the time between when the first eye was treated and then the second eye was treated. So, it depends on how old the patient is and the rate of progression. It's important to know that everyone's progression can be different. So some people progress very quickly, and some people progress very slowly and then stop progressing on their own.
Well, one of the things you mentioned earlier was about a patient who was in their 40s or 50s and had not had a progression of disease, that you don't necessarily think that would be a candidate for cross-linking, but there are patients in their 50s who might still, if their vision was changing, that would be someone who you might consider for the treatment?
Correct. So, with the eye working like a camera, especially at age 50 or 60, there's other things that can change your vision, and the most common thing could be a cataract. So it's important to see, when you look at patients' vision, that you're not just looking at, where their myopia is with respect to their vision, because if the cataract changes, you can actually become more myopic as well. And unless you look at the cornea individually, you may think that that's all coming from the cornea, whereas it could be the actual lens inside the eye. So it's important to get serial topographies and follow the cornea to see if that makes sense, that, hey, is this patient progressing or not? Are they atypical? And if they are atypical, then maybe consider cross-linking despite their age.
Okay. That actually brings up another question someone has mentioned, and that is, if you've had cross-linking, can you have subsequent surgeries like cataract surgery or even LASIK, or are you no longer eligible for any kind of eye surgery going forward?
No, I mean, you certainly are eligible for eye surgery. There's not enough data out there to say that you're safe for LASIK after cross-linking. I think to be conservative, LASIK is probably not your best bet after cross-linking, depending on your particular situation. I know some investigators are looking at surface ablations, such as PRK or topography-guided refractive treatments to improve the quality of image you get from your keratoconic cornea. Certainly, you could do cataract surgery in the setting of a regular keratoconic cornea or even a cross-linked cornea.
Okay. You did mention that people who've had cross-linking are probably still going to continue to have to wear contact lenses. So that makes no difference, cross-linking?
From what we've seen, the ability to wear a contact lens has not been changed by having cross-linking done. Is that your question?
Yeah, that was it. So even if you have the cross-linking, you'll probably still be wearing contact lenses, but maybe the prescriptions won't change quite as often?
Right. The goal is to stay where you are, And if you have keratoconus and have good vision with a contact lens and are progressive, the goal would be to halt the progression so that you can keep good vision in your contact lenses. Patients with keratoconus, contact lenses are often the only thing that can get them satisfactory vision because of the mechanics of how the eye and a contact lens interact. It really gives you really quite excellent vision with a contact lens that oftentimes spectacles don't give you. So the goal is to be able to maintain the ability to continue to wear a contact lens without having a progression of your keratoconus.
Okay, I understand. I got a question from Lydia, and she asks if you can have cross-linking done a second time if you've already had it once.
So currently, that if you do have some response to the cross-linking, and then there are protocols which do, or there are investigations which have had multiple treatments of cross-linking, to again slow down the progression of keratoconus. And I think again back to one of my earlier comments is everyone's condition will be different, and you should speak to your physician about your particular situation and figure out what makes sense for you.
Here's an interesting question that I think sometimes we forget, and you use terms that you think are clear but are not, and this is a great question. One of the listeners wants to know, what's the definition of progression? How much change over how much time is your definition of progression? So,
very good question. I think every study has a different definition of progression. In my mind, progression is different depending on your age and depending on if you wear contact lenses or not. So what is not progression is if you take off your contact lenses and then just say you wear hard contact lenses and then you get checked a couple weeks later and your keratometry went from 47 to 48. That's not enough time to say, hey, that's progression. You need to look at it over a longer period of time without the influence of contact lenses. If you're younger, we know by definition that keratoconus is a progressive disease. It's so if you're very young, just say you're 18, 19 years old, to really wait 6 months to a year to see if you're progressive doesn't necessarily make a lot of sense in my mind. I would think that you're better off going for the treatment because of the possibility and the likelihood that you are going to progress. I don't think there is a defined standard of progression that is universally accepted.
So it's whether your eye doctor believes that things are heading south rather than so it's usually not just one reading, right, but over some period of time, which may be a few months, or can a doctor make the diagnosis and then say that you're a candidate for the procedure in one visit?
So if you're young, I think yes. If you're a little bit, and I don't want to say, late 20s or early 30s is old by any means, but if you're, with respect to keratoconus, if you've had keratoconus for a while and your glasses prescription is not changing that much, and your contact lens prescription hasn't changed much, then maybe you're not progressive. So I think progression is individual, and you really need to see, what's causing your vision to change. Is it the fact that you just stopped wearing your contact lenses, or is it the fact that you're actually, your cornea is actually steepening, where then you would be a good candidate for cross-linking?
Okay, someone has asked how young a person would you treat, or what's sort of the minimum age that someone can be cross-linked?
So, I don't know what the FDA has put as a lower limit for this. As part of the clinical trial, we did have some adolescents, people in 13, 14, 15-year-old patients that were treated. And to me, that's where you have the greatest chance to make the biggest impact. if you can catch someone who's just been diagnosed at age 15 or 16 or 13 with keratoconus, and you are confident that that's the diagnosis, that's where we have the chance to really change the natural history of the disease and really impact this patient's life for decades to come.
Yeah, for the better. Yeah,
Correct.
Okay, well, we've gotten some great questions, but I think we're going to have to wrap up this webinar now. I want to thank everybody who has written questions and who listened in. I hope you found it useful. As I said earlier, we're going to have a recording of this presentation posted on the nkcf.org website next week. National Keratoconus Foundation provides information and materials upon request, so if you ever need anything and there's any way we can help, contact us at info@nkcf.org. That's our email address. We'll try to help you with that. I want to thank Dr. Garg for his talk and for answering the questions. I certainly learned a lot tonight and have a better understanding of what to expect with cross-linking and who the best candidates are and what the outcomes will be. As I said, we'll try to hold regular webinars during 2017 on topics that are of interest. Stay in touch with National Keratoconus. Thank you for joining us, and thank you again, Dr. Garg.
Thank you very much for having me.